next time onwards, what we will be doing is we'll give a summary of our case, okay, before we make a provisional diagnosis, wherein summary is wherein we pick up only the important points or the positive points and then present. So if you have noticed during your Viva, especially if you are the last few people who are presenting, then what does the examiner do?
Rushes through.
Yes. So he will not listen to the whole history. So he'll ask you that, give a summary, right? So each one of you should train yourself to summarize a case. So can you just do it for us, Neha?
She's a 68-year-old multiparous woman who has attained menopause and has a previous obstetric.
You can say postmenopausal. You are summarizing, no?
Okay, ma'am.
60-year-old postmenopausal multiparous woman.
Who has an obstetric history of.
Who is also diabetic and hypertensive. That should also come in your diagnosis.
Okay. And has a history of vaginal delivery with one conducted at home and the other.
No, that need not come in. Okay, fine.
Summary. She's summarizing it.
Yeah, but
okay. Summarizing. Yeah, tell Neha.
Okay, 68-year-old menopausal multiparous woman who is also a hypertensive and a diabetic, who and has a previous history, obstetric history of normal vaginal delivery conducted at home, who came with and comes with the chief complaint of mass protruding out of the vagina since 8 years. Which worsens after physical exertion and reduces on lying down or manual manipulation. And she presents with no symptoms of urinary symptoms or gastrointestinal symptoms.
With non-case of diabetes and hypertension.
Yes,
she mentioned that. She mentioned.
Yeah.
And has no previous surgeries done.
No negatives. You summarize while summarizing. Give us only the positive findings, so that you keep it short. And finally, arrive at a diagnosis.
Okay. And on per vaginal examination, there is a 6 into 8 centimeter mass protruding out of the vagina, which really manipulated and
reducible. You can say reducible.
And with cough impulse positive also.
Yes. And with cervix as a leading point, probably.
Probably third degree uterine prolapse.
Okay. And multiparous you mentioned. You can mention the parity index also. She's para 3 living 3, like that.
Okay, sir.
So if she has 6 children, she's definitely a higher risk for the prolapse, right? So para
yes,
6 means she'll definitely have much more risk at prolapse.
Okay.
Now, how will you proceed with the case now?
Management. There is initially you're supposed to do investigations to deem her fit for any surgical procedure, and then you have to opt for the right treatment. So you have a conservative treatment and surgical.
First investigations will cover, then we'll go for the treatment.
Investigations, mainly you have to do the per vaginal examination and speculum examination has to be done. Then since she's elderly age group, you can send for pap smear. Cervical cytology can also be done.
Very good.
Yes.
Yeah.
Then you have lab investigations is the CBC, and urine examination has to be done to rule out any infection.
Yes.
Blood urea, and since she's a diabetic, you have to check her blood sugar levels also. Then the ECG, because she's a hypertensive, ECG has to be done, and any preliminary heart investigations, cardiac investigations.
One is
Do you want
routine
to do ultrasound?
investigations. Routine
Ultrasound and
investigations, and the other is specific investigations.
yes.
So in routine investigations, you will get a CBC, blood group, and because if we have to operate on her, and also the serology part, and definitely the RBS. Yes. Then
Yes.
specific investigations, what all you will do?
Ultrasound and MRI
Yes.
to localize the defect.
So
No,
what
no, no,
ultrasound?
never. Don't
No
put
MRI.
MRI in prolapse. Okay. Don't get into trouble.
Okay.
Even ultrasound is not routinely done. Especially, I don't think anybody does ultrasound for prolapse in government colleges. I don't know.
Okay, when will
about
you do
private
ultrasound of abdomen in case of prolapse?
Dr.Abhilash already mentioned about it in the history. Do you remember, Neha?
In case of hydronephrosis.
Yes. And what else will you rule out? One of the causes you mentioned in per abdomen examination for prolapse. Mass.
A mass.
Yeah. And one most important investigation you should not miss in gynae case, pap smear. In all prolapse cases, we do a pap smear. If there is decubitus ulcer, also.
Yes, ma'am.
Okay, so don't miss pap smear. Even if you miss scan, it's okay. Don't miss pap smear.
Yes, ma'am.
Okay. Anything else? She's hypertensive. Maybe you'll see serum creatinine also.
Okay, ma'am.
Chronic prolapse. You have to rule out injury to the kidneys.
Okay, ma'am.
Okay. Management. Come to the management.
Conservative management and surgical management. Conservative management is mainly pessary, installment of a pessary, and pelvic floor exercises. But since this is a third degree,
What are those exercises called?
Kegel's exercise.
Yeah, Kegel's exercises.
How is it done?
The woman is educated in order to voluntarily contract the muscles, as in holding the gas or holding urine. It's such kind of an exercise.
Yeah, she has to do it as frequently as possible, multiple times in a day, whenever she remembers.
Yes, ma'am.
So when will you advise Kegel's exercise? Is it for a? Can you advise it for a 3rd degree prolapse, 4th degree prolapse?
No, ma'am. That is to prevent the progression of the prolapse. So mainly in 1st degree and 2nd degree you can advise.
Yes. Very good.
Next is surgical management. The treatment of choice would
You
be
mentioned about pessary. What are the indications for pessary?
pessary. Mainly is if there is a prolapse in pregnancy, and if the woman is unfit for surgery or unwilling for surgery.
Unfit for surgery, like?
Like the age, increased age, or if she has any other comorbidities.
The medical conditions which are not permitting
Yes.
us to do surgery on such a patient. Yes. Okay. So what are the types of pessaries you know of?
Or maybe if she has a decubitus ulcer and you want to postpone the surgery.
Yes, ma'am.
So you can put pessary.
Yes, ma'am. The types of pessary is support pessary and space filling pessary. Broadly 2 types.
And what is it made of? The pessaries. Have you seen a pessary in the college?
Yes, ma'am.
So usually what is that which is used?
Plastic or silicone.
Okay, yeah. So it can be either the rubber or the silicone or bakelite. Yeah. So these 3 things. And which is the best one out of all these types of pessary? It is silicone. Okay, because it is inert.
Okay,
So
ma'am.
silicone pessaries are much better. Okay. How do you determine the size of the pessary to be used?
You have to measure the length of the vagina first, and then ideally you have to by digital examination, and then you have to place the device, and the pessary should not cause any pain. If there is pain, then it is an ill-fitting one.
So, likewise, how you will do a vaginal examination by introducing the two fingers. You will place the fingers such that it reaches the posterior fornix of the vagina. Okay, and from there to the lower border of the pubic symphysis. So that much is that you'll measure, and you'll minus 1.5 centimeter, because that is the thickness of the pubic symphysis. So that much you'll minus. That will be the diameter of the pessary which we'll be using. Okay.
Okay.
So when you can ask also for a lower size and a higher size. Once the patient gets it, you will put it in the make it aseptic, and then you will introduce it. Okay, introduce it, and how is it placed? Where all it gets fit. One is posteriorly into the fornix, posterior fornix, laterally into the it will be held by the spines, anteriorly by the pubic symphysis.
Okay.
Okay. Then after you insert the pessary, you need to make her ambulate. She has to walk around. She should not have any difficulty. She should be able to evacuate her bladder easily. Okay.
Yes.
Then you will ask her to go back. Then how do you follow her up later?
You have to follow her up every 1 to 2 weeks.
Okay.
And if they are comfortable with it, then they can the visits can be can be reduced. But if they are not, then it has to be inspected again, and a well-fitting one has to be placed.
Okay. When you're sending her back, you should tell her that anytime you have bleeding, anytime you have some small odorous discharge, then you have to report to us. And definitely she has to come for the next visit, say after 15 to 20 days. Okay. Then you check again how it is, take it out, clean that area. Okay. If it is bleeding, then you check it. If there is any ulceration formed or anything, you just check. Clean that, and also the pessary, and reinsert and send her back. Okay, she should be trained to do it herself, wherein she cleans it up and places it back. Okay, what are the complications of pessary?
One is can cause erosions and ulcerations causing bleeding.
Yeah.
It can cause ulcers, pessary ulcers. Another one, it can cause, because of the increased pressure, it can result in pelvic pain.
Yeah, it can get dislodged, and it can cause all fistulas. Some person is also telling. Yeah.
Yes.
So this is one of the conservative management. That is pessary, and one more is Kegel's exercise. Okay. Then further.
Surgical management, the treatment of choice in her would be vaginal hysterectomy.
Okay.
And there is also vaginal hysterectomy with pelvic floor repair in case of cystocele or rectocele present. In case that this is in women who have completed their family. In case if the woman has not completed her family, then we opt for modified Shirotka's operation.
See, now one thing as students you need to be very careful is when you're presenting a case and a management is asked, you will be speaking only about your case. Is it clear? And if in case the scenario is changed, then you will speak. So in your case, 68-year-old with diabetes, hypertension, and say third degree prolapse, what you will do? What is our management?
Since she has comorbidities, then so vaginal hysterectomy would not be ideal. So we could go for a leaf-Oates repair.
Okay. One thing is we have pessary insertion for her. If
Yes.
she wishes for it, yes, we'll go for pessary insertion. And also we can make a fit depending on her medical condition, what degree it is. Based on that, we can go for vaginal hysterectomy, that is Mayo-Wards hysterectomy. Yes.
Yes.
Then if not, we can go in for leaf-Oates procedure, because if depending on the severity of the comorbid conditions which she has. Right now,
Yes,
what
ma'am.
is this Mayo-Wards hysterectomy?
Mayo-Wards is vaginal hysterectomy plus pelvic floor repair.
Yes.
In case of vaginal hysterectomy, there are 4 things to be done. First is clamping and cutting of the uterosacral ligaments, and then next is the clamping and cutting of the cardinal ligaments. Then you clamp and cut the uterine arteries, and lastly you clamp and cut the round ligament, fallopian tube, and the other tissues. Now ovarian ligament, and then you remove the uterus, and then you complete the repair.
You said about the uterine prolapse and vaginal hysterectomy. What about the pelvic floor repair?
Pelvic floor repair is anterior colporrhaphy and colpoperineorrhaphy. Anterior colporrhaphy is done in case of cystocele, where the anterior vaginal wall, there's a T-shaped incision put, and you reach the bladder, and then the bladder is pushed inside, and then you repair it. And in case of colpoperineorrhaphy, the incision is that is done to correct the rectocele.
Yeah. Okay. So these 3 components, that is vaginal hysterectomy with anterior colporrhaphy and posterior colpoperineorrhaphy, together it is called Mayo-Wards hysterectomy. Okay.
Yes.
Then what is leaf-Oates procedure?
Leaf-Oates procedure is it's done in elderly women where there is medical risk. So they usually do it under local anesthesia or epidural, where the anterior and posterior vaginal walls, they are excised, and their flaps are then sutured with catgut, and there will be a wide area of adhesion which is created in the midline, and that will prevent the uterus from prolapsing.
Is it? Yeah. Okay. So it is leaf-Oates colpoclysis, which is partial. Only some bit of the vaginal wall is denuded or it is scraped off, and then it is sutured such that healing and fibrosis will prevent the prolapse of the vaginal wall. Okay.
Yes.
So this is one of the obliterative procedure. What are the other things?
For this age group,
Yeah.
you have sling operations.
This obliterative, mainly I meant that, see, now vagina is obliterated. You close the vagina so that the prolapse is prevented, right? So these surgeries are called obliterative surgeries. One you said is leaf-Oates partial colpoclysis. One more is a complete one, where almost all around the tissue of the vaginal wall is scraped out, and you put sutures through and through the anterior and the posterior wall. So that is complete colpoclysis. And the other is colpectomy. Okay, where the vaginal wall as such is totally taken out, and it is usually followed by hysterectomy.
Okay.
Okay, so these are obliterative procedures. Fine. Okay, what is a treatment for decubitus ulcer?
Decubitus ulcer, mainly you have to put in a gauze soaked with the glycerin in order for it to heal.
Why are you using glycerin?
Because it's hygroscopic in nature, and it reduces the congestion there.
Okay, what else you'll do?
In a case of vaginal atrophy, we can prescribe an estrogen ointment.
Okay, estrogen ointment when in postmenopausal age group.
Yes, ma'am.
Okay. Yes. What else you will do? Don't you want to reduce it? The ulcer is because
Yes.
of the position,
Yes, ma'am.
right?
Yes.
And ulcer is seen in the most dependent area. It's because of the congestion, correct? So, your
Yes.
most important thing in treatment of this decubitus ulcer is you will reduce the prolapse.
Yes, ma'am.
Wherein you can use either vaginal douching, vaginal tampooning with antiseptics, or you can as well use the pessary for reduction. Okay. Now you have done all possible things. Still, the ulcer is not healing. What you'll do?
Send in pap smear.
Pap smear. Okay. Why? What you want to look for?
If it has turned into a malignancy, then the treatment would differ.
A pap smear is better. The other day we discussed when there is ulcer, then when you are scraping that area, definitely there will be blood cells. And when you have pap smear with blood cells, can the reading be proper? Right? So which is better
No.
option? A biopsy.
Biopsy would be better.
Okay, a biopsy from that ulcer to rule out
Malignant.
non-healing ulcer. We need to think in terms of differential diagnosis for non-healing ulcer. Yes, it could be malignancy.
Or a
Yes.
true.
Malignancy.
Or because she is diabetic, there can be trophic ulcers.
Correct. Non-healing ulcer could be because of diabetes, or it could be because of tubercular etiology or a syphilitic etiology.
Yes,
okay?
ma'am.
Okay. Then what else? Okay, this lady, say her age was 30 years, and she has presented to you with prolapse, and she has no children. So it is what? Nulliparous prolapse.
Nulliparous.
So what is the mode of treatment for her?
Treatment would be first you have to rule out the if it is a prolapse or a congenital elongation of cervix or not. And you have to rule out the connective tissue disorders as well. Then operative measures would be the modified Shirotkar's procedure.
So these are all sling procedures.
Sling
right?
procedures.
Yes. What are all the sling procedures you know of?
One is the abdominal sling operation.
Okay.
Then the Manchester Fothergill's operation.
Fothergill's is done for?
But the fertility is reduced. It is done above 40 years of age. Usually.
Okay, we'll speak about Manchester or Fothergill's operation later. We'll speak about sling operations. What are all the sling operations? Purandares, yes. Then somebody's typing it.
The Shirotkar's abdominal sling.
Shirotkar's, then Virkuds, Khannas. These are the 4 sling operations.
Okay.
Okay. So these are all abdominal procedures. How was it done? Can you just tell us the steps? Okay. Now, what is done?
They use a muslin tape, wherein on the they usually secure the uterus from the left to the right side, and on the left side they make another sling in order to prevent compression of the sigmoid colon, and attach it to the sacrum.
Okay. Okay. So basically, the principle behind the sling operations is that you give a support to the cervix by attaching usually uses a muslin tape. So you will attach it to the isthmus, and then you will again, this isthmus is attached mainly to one static point. Okay, it can be the sacral promontory or the rectus sheath. Okay, so this is a principle. So that will prevent the prolapse of the organ. Okay, now in Purandares, it is like the isthmus, anterior part of the isthmus is attached to where the rectus sheath. Okay, and in what is that? Shirotkar's, what is done is the posterior part of the isthmus is attached to the sacral promontory. And Virkuts is a combination of these two, wherein posterior part of isthmus is attached to sacral promontory and anterior part of the isthmus is attached to the rectus sheath. This is Virkuts. And Kannas is wherein the the posterior part of the isthmus is attached to the periosteum around the anterior superior iliac spine. Okay, so these are the 4 sling surgeries. So now you have done sling surgery for her. Now she has luckily her prolapse is corrected and she becomes pregnant. Is it mandatory for such a patient to undergo cesarean, or she can have normal vagina? She can have
She can have normal vagina.
Yes, she can have normal delivery. Okay. Okay. This is about sling surgeries. Then, anything you would like to add, both of you?
What is incarcerated prolapse? If there is irreducible prolapse, you cannot reduce the prolapse.
Fothergill's operation or Manchester's operation. What is this?
Yeah.
Fothergill's operation is where there is. Yeah, the Fothergill's operation is where there is a amputation of cervix is done, and the McEnroe's ligaments are brought forward in front of the cervix, and in order to strengthen the cervix, and then you do the anterior colporrhaphy and colpoperineurrhaphy if indicated.
What else? What are the complications of vaginal hysterectomy for prolapse?
Mainly, there can be damage to the there increased risk of hemorrhage, anesthesia risk, sepsis, and urinary tract infection, and also trauma to the bladder and rectum also can occur.
Okay.
And in later on, there can be a vault prolapse as well.
You can divide the complications into anesthesia complications, intra-op complications, early post-op and late post-op.
Say immediate complications. What can happen?
Hemorrhage.
Complications.
Okay.
And trauma, that is to the bladder and the rectum. Post-op is retention of, it can also cause retention of urine.
Yes.
And because of this, there will be infection leading to cystitis.
So immediate complications are all the anesthetic complications, then the primary hemorrhage, then the injury to the bowel and the bladder.
Yes.
Then what is that? Immediate early complications. Early complications can be reactionary hemorrhage, wherein it can happen because of the slippage of the ligatures which we have put. Okay, and in the post-op ward, on the first and the second day, what all can happen? She can go into dehydration, electrolyte imbalance, paralytic ileus. Yes, after 2 days she can have infections.
Yes.
Then there could be thromboembolic phenomenon because it's a prolonged surgery. Usually vaginal hysterectomies go on for more than 45 minutes, right? Then she is at risk for thromboembolic phenomenon. Then later on, again, secondary hemorrhage after a few weeks, she can come with that, wherein there is a crust formation at that area of healing and that opens up and she bleeds. Then what else? Late complications. One is secondary hemorrhage. Then
the recurrence of prolapse, that is vault prolapse.
Vault prolapse, yes.
Then because of the bladder and the rectal injury, she can have other fistula formations.
Yeah, vesicovaginal fistula and rectovaginal fistula. That's why during the procedure itself, it's very important to detect the fistulas, or the injuries, because it heals better when we operate immediately.
Yes, ma'am.
We can tackle it better if we operate immediately. So these are the complications. Okay. Now, how do you treat vault prolapse?
Treatment is mainly you have the sacrospinous colpoplexy. That is, you fix it to the sacrospinous ligament.
Always go from conservative methods. Yes, we have pessary. We still can keep a pessary, correct? Then we'll
Yes,
go and do any surgery or anything. Yeah. First is a pessary. Then what else?
The colpoplexy.
Okay. Again, that is abdominal method. So best would be a vaginal method. So next answer should be a vaginal method. What are the vaginal methods to treat vault prolapse? We have Meckel's scaldoplasty and we have sacrospinous ligament fixation. Okay, so what are they for vaginal route of correcting the vault prolapse? One is
the Meckel's scaldoplasty. Then you have the
Meckel's scaldoplasty and then
sacrospinous colpoplexy.
Sacrospinous ligament fixation.
Abhilash,
Yeah.
can you answer questions from chat section?
Oh, wait.
Is there any definition of chronic cough and chronic constipation? Somebody has asked in chat section.
I think 6 months we take as cutoff for.
Yeah, 6 months. 6 months. Why stress urination is important?
But we answered, I think.
Yeah, we have answered. Maybe if somebody has not understood. Sometimes there can be occult stress urinary incontinence, which is not seen when the patient has complete prolapse. And when you do surgery for prolapse and reduce the prolapse and do pelvic floor repair, then it may come again. So you have to repair stress urinary incontinence during the time of prolapse surgery itself. Okay, what other questions? Any drugs that might predispose to weakness and prolapse? I don't think so.
Smoking can, if you consider the drug.
Yeah. Okay. Are we expected to do PV examination in our exams?
No, you will be given the finding. Few of us give the finding in the exam.
Yeah, PGs generally give the findings to UGs. So you can just present that.
Okay. How do we know the labor was prolonged?
Yeah.
That question.
If she
How
has
do
the
we know
complaints,
labor was prolonged?
yeah,
So for that,
how do we
if
know?
2 sunrises or 2 sunsets, she has seen that generally prolonged.
If she has complaints from 8, why has she presented now? Somebody has asked. Neha?
Yes, ma'am.
Can
That
you
is
answer?
probably she hails from a lower middle class family, and she might not be aware of the situation. So now maybe it has gotten more severe the past few months, so she has presented now.
Okay.
You
I
have
don't
to
know
mention
for
that usually symptoms increase. Suddenly,
Yes,
she won't be able to void the urine without reducing. That may be the reason she has presented now. That you have to elicit. Or
Yes,
difficulty
sir.
in walking.
And one more thing which you have to mention is for UGs, I'm not sure if they are particular. For PGs, they used to ask us to mention whether she is sexually active. It's important in repair.
Okay, ma'am.
It's important in the management of prolapse. And how to tell if cervix is the leading part?
The opening will be present.
Yeah, the lowermost part of the prolapse. That you will see with experience if you see more findings, more patients with prolapse, maybe you can make out. Is the cervix always the first part to come out? Not necessarily. Okay. there can be just cystocele or rectocele in which cervix is not the first part to come out. And they have asked what all should a summary include.
For the summary, we already discussed. I think 68-year-old age, parity, menopausal status, then what chief complaints she presented with, what are the positive things, and then on the positive findings on the examination. Then you come to the diagnosis.
Yeah. Okay. What if a patient comes in with a forgotten pessary?
So she already mentioned about complication. We check for all the complications and remove the pessary.
Yeah.
Okay. There's someone asked about dorsal position and lithotomy position difference. Can you answer, Neha?
Dorsal lithotomy position is wherein the legs are raised up with the help of a support, and dorsal position is in the lateral position.
A dorsal is not lateral, no? Dorsal when she's on back with legs by the sides.
Yes.
It's not hung. So what is vault? What is vault? Vault represents the scar where the previously cervix was cervix is located. Okay. And okay, can you determine the pessary size? Neha, ma'am already explained, no? Just repeat for benefit of everyone.
The pessary size, so you have to usually measure the vaginal length by a speculum examination, and then you have to have a higher measurement one and a lower measurement one.
No, ma'am told two-finger method, no? During PV examination, 2 fingers you insert, reach the posterior fornix, and take till the symphysis pubis. Take till the symphysis pubis and subtract by 1 centimeter usually, because pessary will be sitting in the posterior fornix and pubic symphysis. Okay. How will you prevent wall prolapse? You have done abdominal hysterectomy. Will you do anything to prevent future prolapse, wall prolapse?
I don't know, sir.
You can fix some ligament to the vault. No, which ligament?
The cardinal ligaments.
Uterosacral ligament we fix to the wall to prevent prolapse in the future. Okay. And during vaginal hysterectomy, as ma'am told,
Ma'am already mentioned one more procedure, no? Anusha ma'am mentioned one procedure, vaginal procedure.
I told it, Meckel's. So we can do Meckel's caldoplasty. Usually external Meckel's is there and internal Meckel's fixation we do. You can see usually it's done during vaginal hysterectomy. And from exam point of view, vaginal hysterectomy with pelvic floor repair procedure is also important. Some examiners usually they'll directly go to the diagnosis, management, and ask about the procedure. Any related procedure they can ask. Procedure of hysterectomy, or in this case, definitely vaginal hysterectomy with pelvic floor repair, they'll ask. Okay.
And please include pelvic floor repair in your management. Don't just say hysterectomy.
And few people actually don't like they don't like pelvic floor repair. You mention as vaginal hysterectomy with anterior colporrhaphy and posterior colpoperineophy or Ward-Meyer's procedure. Okay.
Yes.
So in case you answer all these questions very well, and then asked at the end they'll ask you, how do you treat stress urinary incontinence? PG level questions.
Again, you start with conservative.
Okay.
Yeah.
Yes. Somebody has mentioned transobturator tape and transvaginal tape.
Yes.
Okay. Good. Did we miss out on anything, Dr. Mangala and Dr. Abhilash?
I think we covered all, I think.
Yes.
Except for the Fothergill's operation.
Yeah.
So when is Fothergill's operation opted?
In case of if the woman does not, if the woman requires a preservation of the uterus but does not want any more further children, has completed her family.
Is done in what case? Elongation of cervix.
Elongation of cervix.
Yes.
Cervix.
Yeah.
Steps of Fothergill's, I mean, components of Fothergill's are they supposed to know?
Yes. Again, a PG level question to get grace marks, higher marks than other people. So if you answer even that, then yes.
In Fothergill's operation, the major part is the amputation of the cervix. They do amputation of the cervix, and then they bring in the cardinal ligaments forward, and in order to strengthen the cervix.
And attach it at the Fothergill's points, which are situated on the lateral side of the cervix.
Okay.
Yes, very good. And what is that kind of suture which is used?
Purse string suture.
Stum-Dorf sutures.
Okay.
Okay.
Okay. Good.
Few take-home messages with respect to uterine prolapse in case you become gynecologist later on. Yes.
Yeah. Yeah.
So one thing is, see, all cases of prolapse need not undergo surgery. Okay, it depends on it. The treatment option depends totally on what the patient wants. What is her desire? What is her concern? Based on that, the treatment procedure goes on. And before, it was like for every case we used to do vaginal hysterectomy, but now it is more so of site-specific repair. If you find cystocele, you treat cystocele. You don't have to touch the uterus. So it is site-specific. And most often, and we all have to look into anatomical restoration. Wherein, when we are doing surgery, whatever is a function of each organ, say vagina, whatever is a function of that organ, we need to make sure that we restore it. It's not like at the end of surgery, we leave a vagina which is just 3 centimeter, 2 centimeter length. Okay. So this should be we should keep it in our mind. And always surgical procedures to be put across if it is more than 2nd degree prolapse. Till then, you can go for conservative management. For any case, you can go for conservative management, especially Kegel's exercise and all can definitely be told to them.
Yes, ma'am.
Yeah.
Thank you, ma'am.
And students, please go watch a case of surgery of prolapse surgery if you get to see. Otherwise, you won't understand anything from textbook. If you don't see it, you will not understand. Please see and ask your surgeons to describe every step in detail as they do the surgery. Ask them, and then you can understand better.
And what I was just thinking is next time onwards, see, as students, one thing very important is that you note down all the questions which are asked pertaining to each case whenever there's a case discussion happening, because these are the commonly asked questions. So more than writing up the answers, I'll ask you to write up the questions, because anyways answers you will find in the textbooks and everything. Yeah. So note down all the questions definitely. Yeah.